For those of you who don't know me, my name's Malcolm Campbell. I'm the Vice President of Research here at University of Guelph, a job that I've enjoyed for, it'll be 5 months actually next Monday. So still relatively new on the job. It gives me the greatest of pleasure today to introduce the inaugural speaker for the Center of Cardiovascular Investigations. And he's standing right here beside me, Gavin O'D. For those of you who are not familiar with the Center for Cardiovascular Investigations, the CCVI itself has only been underway, I would note, only a month longer than me. It's in a half year in its existence. It started in May 2015, and it brings together researchers from across University of Guelph who have been working together in the area of cardiovascular research for quite a while now, and have had an impressive go at it as a group working together, garnering over $8 million in competitive grant funding since 2011. So a very impressive group of researchers indeed, and congratulations to all of you who are here in the room. I imagine that many of you are representative of that particular group. The CCVI has 3 main goals, and I'll divide these into 3 specific areas. They really amount to bringing together ideas, people, and facilities. So in the first instance, ideas, the Center for Cardiovascular Investigations combines our expertise as one of the few centers worldwide, so global expertise, looking at cardiovascular disease all the way from single molecules to clinical applications, so from bench to bedside. It's a place that brings people together. So it's going to support the ambitious teaching and networking programs involving faculty, students, and staff, and a growing network of national and international allied institutions and research programs. And we see one of those allied programs here today. And finally, it brings together facilities, really, truly exceptional facilities, cutting-edge facilities in preclinical imaging, and that enables us to translate laboratory successes to direct clinical applications. So this is truly groundbreaking research that is going to drive the field of cardiovascular investigations forward. It's completely along these lines that we have today's inaugural speaker with us. And today's speaker is Dr. O'D, Dr. Gavin O'D. Dr. O'D completed all of his degrees at University of Toronto, so his undergraduate degree as well as an MD PhD program at U of T, and then proceeded to do excellent work in the laboratory of Peter Back, not only for his graduate studies, but also going forward and doing postdoctoral research there at Toronto General Hospital. And it was truly research that went from bench to bedside, work that he'll describe to us today that has now moved into clinical trials. Following on from that excellent start at University of Toronto, he proceeded to Edmonton, where he now is Canada Research Chair in Heart Failure, an Associate Professor at the University of Alberta, Clinician Scientist at the Mazankowski Alberta Heart Institute, where he has been doing absolutely spectacular research. And again, moving from bench to bedside, and he will be talking to us in the second half of his talk today about work that he's done in his new group well, not so new, 7 years. 7 years. At University of Alberta, working together with his team there to, again, move things into the translational realm. Dr. O'D's research activities are diverse with a primary emphasis on heart failure and arrhythmias. His clinical activity places a primary emphasis on heart failure, which includes patients with iron overload cardiomyopathy, Fabry's disease, metabolic disorders, and idiopathic dilated cardiomyopathy. By the way, I think I deserve some applause there as a plant biologist for getting all my words right. He's Canada Research Chair in Heart Failure. And 2 quick notes. If you're wanting to have a chat today with Dr. O'D, the Center for Cardiovascular Investigation invites graduate students and others who would like to chat with Dr. O'D after his talk to introduce yourself, and there'll be some food drivers that will get you there, Timbits for dessert while you're visiting. Final note is it gives me the greatest of pleasure underscoring the wonderful partnerships that we have here at University of Guelph, that I welcome a representative from Elanco, who is not only supporting today's talk, but will be presenting a plaque to Dr. O'D on behalf of the Distinguished Speaker Series inaugural seminar event.
Great. Okay.
So hi, I'm Dr. Kristen Butler. I'm the Veterinary Technical Consultant for Elanco Animal Health, and it is with great pleasure that I present this inaugural plaque, which is basically for inaugural speaker and distinguished scientist, to Dr. Gavin O'Keefe.
Okay, great. Thank you very much. Thank you. Okay.
And with no further ado, Dr. O'Keefe.
Okay, great. Thank you very much for that very, very kind introduction, and I would like to thank Tommy and Glenn and colleagues for inviting me to be your inaugural speaker. It's a pleasure to be here and to connect with old friends and colleagues. So if we can just get the lights down at the front. So, and I know some of you have your notebooks out and stuff like that, so you can, what I'll do is load the slides up afterwards as a PDF so you can have access to the slides. I think Tommy would be willing to share that with you. So you no need to take notes as we go through this. So I think the theme we want to talk about today is precisely what Dr. Campbell talked about, and it's precisely the philosophy of your cardiovascular center. And the concept is that we can go from a molecule and translate not that only into care for animals, but also care for patients, and to discover better therapies. But certainly one of the concepts that we do need to pay attention to as we move ahead is the concept of personalized medicine. So oncologists have kind of mastered this art, and current cancer therapy is really a therapy about personalized medicine and tailoring therapies to sort of what exactly your cancer diagnosis is. We hope this concept can now be applied to cardiovascular disorders, and you will, I think in the next few decades, start to see these kinds of approaches now being applied. So what I'll do today is illustrate this concept using talking about two different therapies. One is the L-type calcium channel blockers for iron overload disorders, cardiomyopathy, and then something we have done more recently, looking at human recombinant ACE2 as therapies for heart failure, so a different type of heart failure. So I do need to show you the slides so that you can influence your politicians that this is an important stuff. And as I said, you will have copies of these slides. So American data, Canadian data, so the curves are basically overlapping, but males and females, the prevalence is just simply on the rise. So we're expecting a 2 to 3-fold rise in the prevalence of heart failure over the next few decades. Now, some of this is a product of our success. People with heart attacks, for example, and with heart failure now live longer because we have better therapies. But with the aging of the population, rise in obesity and diabetes, prevalence of heart failure now is becoming a major issue. And not surprisingly, what comes with that is a huge economic burden. So this is US data, but you can just divide this by 10, basically, or differences in population. So the annual cost of heart failure care in Canada is $4 billion. Most of that now is dealing with patients during their hospitalizations. This is now a chronic condition that we have to manage repeatedly over and over. Our salaries, by the way, is the smallest portion of this pie. So it's a disease. It's not the physicians. So major public health issue. It is now the most commonly diagnosed condition in the elderly, with a prevalence of 1% in the elderly population. So huge economic burden. So what I'll switch to now in terms of the science. So one of the things, I started working with Peter Bax, I guess, in 1998. So very early in my training, I started to work with Peter. And so one of the things we worked on initially was a condition called iron overload cardiomyopathy. So it is a heart disease condition that you get with patients, predominantly in patients with secondary iron overload. So these are patients with sickle cell anemia, beta thalassemia major. And here is a recent review that came out in circulation that highlights the importance of this type of disorder. This is taken from a review article, and basically with increased exposure to iron, and in patients with anemia, thalassemia and sickle cell anemia, you get this injury pattern because of increased blood transfusions that these patients require. And with that, you get progressive heart disease, and ultimately you end up with a dilated, very advanced cardiomyopathy. What's striking about this is that there are no effective therapies for this condition. So this isn't a condition that responds very well to ACE inhibitor, to beta blockers, and some of the conditional therapies. So chelation therapy does work, and some of you probably are aware of the Nancy Olivieri story and the controversies regarding chelation therapy. So that is referring to iron overload. So what I'll talk to you today is a discovery from basic science that have now made it into phase 2, phase 3 clinical trials. And basically the concept is understanding why patients with iron overload, so this is the realm of hematology, why is it important for cardiovascular science and cardiovascular medicine? So this is a world map of the prevalence of these congenital anemias and a hereditary form of iron overload, so the primary hemochromatosis. And this is a condition that affects mainly the Caucasian population. And it is, so what is the world's most common autosomal recessive disorder in Caucasians? Primary hemochromatosis. So again, something that a lot of people don't know about, but the penetrance of this disorder is low, but it is the most common disorder in the Caucasian population. What is the most common genetic disorder in non-Caucasians? Thalassemia and sickle cell anemia. So these conditions are very prevalent because they confer some type of survival advantage, and which is why, going back to basic Darwinism, this is why they're so prevalent. And we know for sure thalassemia and sickle cell anemia protects people from malaria. Okay, so the changes in the red blood cells that these mutations cause protect individuals from malaria infection. So this is why they're so prevalent. And as you can see, in the Middle East, India and China, and in parts of the US and in the Caribbean, these conditions are very prevalent. So, you know, maybe not very common here in Guelph, but on a worldwide basis, these are very prevalent conditions. So hematology meets cardiology, and these are 3 seminal papers that were published initially in the Lancet, and then 2 papers back-to-back in the New England Journal of Medicine, 1994, and one of these were headed by Nancy Olivieri. And so they all showed the same thing, that the most important driver of survival in these patients is not the primary hematological disorder, but it is indeed the development of heart disease and cardiomyopathy in particular. So for once, hematologists had to become cardiologists, and cardiologists had to pay attention to hematology. So why would a hematological disorder have cardiomyopathy as its main determinant of survival? So I think we need to start thinking about that as I go through the presentation. So here is just a simple example of that slide from Olivieri's publication. And ferritin is a marker of the amount of iron that you have. If you have very high ferritin, your survival over a 10-year period is less than 25%. So very aggressive disease. And of course, if you have very low iron burden, then your survival is relatively preserved. So a striking demonstration of what the degree of iron overload can do to the heart. And this is an example from a very old publication, 1964. It is still the official publication in disorder. This is a child who died from sickle cell anemia. So this is described in the southern US. You can see the enlarged spleen, protuberant abdomen due to ascites, pigmentation due to the iron deposition, a very cachexic looking upper body, and a chest x-ray that shows a globular heart. So this is biventricular dilated cardiomyopathy. So a well-recognized entity, and so we now know that in secondary iron overload, heart disease is the number 1 cause of mortality. In primary hemochromatosis, liver disease is more prevalent. And some of that is simply the reflection of when you have increased gut absorption of iron, it hits the liver before it hits the systemic circulation, as opposed to when you get a blood transfusion, which then is directly systemic and does injure the heart more directly. So This is the more aggressive form of iron overload and does lead to a very high prevalence of cardiac disease. Pediatric iron poisoning is also an important entity. This is now much less because of labeling of so kids who take the parents' iron tablets as mistakenly, and it is an important cause of mortality. So you can also get acute iron toxicity from this. So to understand why the heart is so affected in this condition, we have to go back to understanding the basics. And going back to the basics mean really the basics. So this is a classic figure taken from one of the reviews on iron overload. So humans, like most vertebrates, we evolve a system to conserve iron because our evolution was shaped by an environment in which iron was very deficient. So we have created a very effective way of conserving iron. In fact, humans do not have a way of excreting iron. So we actually have no excretory pathway. So this is important in minimizing anemia and conserving iron, but when you're in a situation of iron overload, this is a disaster. So you now hold on to your iron much readily than you would like. Okay, so the only way you lose iron is basically through your gut, through GI blood loss. So this is an important concept that certainly further perpetuates iron overload disorder. So Peter Bax and colleagues in the lab start to look at why the heart in particular is sensitive to iron injury. And here we've shown that transferrin-dependent intake of iron, which is under negative feedback, is turned off during iron overload. And what happens in iron overload condition, you have this transferrin-independent appearance of iron. And what I'll show you data is that this iron is the one that's reactive. And the reason why the heart and also some endocrine tissues, these patients all get high prevalence of diabetes and injury also to the anterior pituitary gland. And the reason for that is because iron permeates the L-type calcium channels. And this is the explanation for why you get a cardiomyopathy and why you get endocrinopathies. So the L-type calcium channels are the important target here for iron entry. So what are these molecular structures? So this is an example of a cardiomyocyte. You've probably seen many examples of this. This is the dimension of it. And in this membrane here, the sarcolemma of a myocyte, you have these beautiful invaginations. So these are T-tubules invaginations. And embedded in these things are the L-type calcium channels, okay? And what they do is they let calcium in from the outside and they trigger calcium from the inside, and this is what triggers the whole excitation contraction coupling, okay? And this is what leads to cardiomyocyte contracting, and of course relaxation is a reverse of that. So these are absolutely key structures, ion channels in the heart. And here is a schematic of what the calcium channel would look like. So a very large protein, there are 4 major domains. Now what's important here is that we have very good pharmacological tools to block these channels. And of course these tools, you probably have recognized these names, they're used to control blood pressure, hypertension. So they are widely used medications to block calcium channels, and they are very effective antihypertensive agents. So what's encouraging is that we have identified the target by which iron gets into the cells, but we already have drugs that work very effectively on these channels. And here is probably the most basic study we have done showing that in a Langendorf heart, this is using radioactive iron. I'm not sure you can probably do these experiments now, but 20 years ago, we did them with radioactive iron uptake in a Langendorf heart. And we also did patch clamp experiments and showed that the iron does permeate in via the L-type calcium channel. So the L-type calcium channel is somewhat promiscuous. It allows calcium in. It also allows magnesium and iron in. So, and that has some physiological role, but what I'll show you here is a clear example of where it's pathological. So that's the basic science experiment. So then we, of course, moved on to doing animal work. So we designed basic wild-type mice injected with iron, subacutely or chronically. Here is a beautiful electron microscopy. So this is the surface of a myocyte. These are beautiful iron deposition. This is the nucleus. As you can see, this is a cluster mapping of those iron deposition. This is an X-ray probe of those granules. So this isn't glycogen deposition or lipid deposition. These things contain iron. Okay, so this model worked very well. So to test the hypothesis that in these animals we can lower myocardial iron levels and protect the heart, we treated them with 2 calcium channel blockers, verapamil and amlodipine. And in particular, amlodipine here is impressive. It's one of the dihydropyridines. And as you can see, whether you inject iron in a subacute or chronic, you have a dramatic reduction in myocardial iron uptake. Okay, at least 50% reduction in myocardial iron uptake. This is a beautiful Prussian blue staining. This is what's used clinically to detect iron overload. So a normal myocardial section, an iron overload section. And you can see here, there's extracellular deposition of iron, but there's clearly a blue haze here within the myocytes. And in response to calcium channel blockers, what you can see is the extracellular iron is still there, if not maybe slightly increased. But that blue haze within the pink structure here is dramatically reduced. So what we're doing is selectively blocking the iron entry into the cardiomyocytes, into the myocardium. And the opposite of this is what happens if you overexpress that calcium channel. And so we did this with a transgenic model and showed quite the opposite. So using a genetic model, we have shown that you can increase the iron uptake into the heart if you overexpress the L-type calcium channel. Okay, so loss of function experiments with calcium channel blockers, gain of function experiment using genetics, showing that you can clearly modulate iron uptake at a very macroscopic level in the myocardium. So, this was very exciting for us. We managed to get this, so 5 years of work. So I've shown you only 5 or 6 slides here, but this was 5 years of work. We managed to publish this in Nature Medicine, and then this was further supported by a study from Germany, which had a slightly different interpretation of the transport business, which basically reproduced these findings and suggested there may be another transporter that are also involved, and maybe the liver is also protected by these drugs. So what do you do now? So this is a very nice sort of a basic science experiment. We went from basic molecule cardiomyocyte work to the whole animal work. And now how about our patients? This is particularly important because the therapies for these patients are limited. So it's chelation therapy, it's expensive, there's lots of toxicity, it's limited. So remember, these are patients who are affected in underdeveloped nations or developing countries that simply can't afford chelation therapies. So having a calcium channel blocker therapy for these patients are absolutely important. So this is a pilot trial done in Brazil, looking at amlodipine. It's a very small study, 10 controls, 5 patients with amlodipine, so 15 patients with thalassemia major. And what they have shown that over a 12-month period, they can lower the ferritin level, but importantly, this T2 star, the data is variable. So the T2 star, which I visited your MRI center, can do this. It's a measure, an inverse measure of the amount of iron in the heart. So higher levels of iron in the heart lowers the T2 star. So by lowering the iron, you're elevating your T2 star here. So pretty dramatic results. This has now led to 3 different trials that are ongoing. So these are all in clinicaltrials.gov. And you can see one in Pakistan, one in Brazil, and one in Canada in Toronto. So precisely the areas where you'd want to do these trials. So these are the areas where prevalence of secondary iron overload is quite high. So a very exciting approach for us. We've gone from a basic electrophysiology observation, and now we have moved this all the way now into phase 2, phase 3 trials in patients. But it took now, this is now happening, 2015. We started working on this in 1998. So 17 years, right? So that's sort of the time frame. You're looking at 10 maybe now you can crunch that down to 10 to 15 years, but the bottom line is, you need to put your time in and do what's necessary to show that this stuff works. And so, we're not out of the woods yet, and we hope these trials, so these studies are going to be pivotal in showing us whether calcium channel blockers, and all of these trials are actually using amlodipine, which is probably the preferred agent to be used in patients with iron overload. So we're very excited that one of our discoveries have made it into clinical use. But today is also a talk about personalized therapies. So do not leave here thinking that all of your heart failure patients should go on amlodipine. In fact, if you do not have iron overload cardiomyopathy, you should not get amlodipine, okay? Because in the other types of heart failure, so patients with just dilated cardiomyopathy for genetic reasons or post-MI heart failure would not benefit from amlodipine. And that's because amlodipine is not targeting the basic pathophysiology in those patients. So why would you use amlodipine in those patients? And in fact, people proposed way back that amlodipine could make an impact in patients with heart failure, and so it doesn't. So that this just came out, I guess, a year and a half ago, where they showed that patients do worse. Patients without iron overload cardiomyopathy that get amlodipine. So this is, so we're now starting to unravel this concept of you got to understand your patients, understand the pathophysiology, and then apply the therapy as needed. So anyway, so amlodipine, not for everybody, hopefully for iron overload cardiomyopathy. Okay, so what does work for your bread and butter heart failure? Well, this does work. Okay, so this is how we treat patients with heart failure, and as Lynn indicated, this is how we treat, I think in the veterinary clinic, this is how we treat heart failure, for example, in your Doberman pinchers with heart failure. These are the type of drugs that we use. This is what these drugs, ACE inhibitor, aldosterone antagonist, beta blockers. So these are antagonists of the neurohumoral pathway. So these are the systemic activation of these pathways that have led to the use of these drugs, and they have made an impact. So we now, survival now with heart failure is down to about 10%. Of mortality rate now that's about 10% per year. Okay, it started off at 1/3. So in about 3 years, all of our heart failure patients would die. So now they live up until at least 10, 15 years with heart failure. So quite dramatic improvement. Now, how can we target this pathway even further in a more personalized manner to treat the other type of heart failure, the maybe more common type of heart failure in this part of the world? So who knows about the renin-angiotensin system? Everyone knows about the renin-angiotensin system. So, well, in the textbook, this is the way it's drawn. Angiotensinogen gets converted by renin to angiotensin 1, then by ACE into angiotensin 2, and this acts on its receptors, right? This linear pathway. Well, what's missing from all of this is what turns it off. And so a discovery by Joseph Penninger, which we were very happy to be involved with, discovered this new enzyme called angiotensin converting enzyme 2. And what this does, it breaks angiotensin 2 into angiotensin 1 to 7. So 8 amino acid peptide gets converted into a 7 amino acid peptide. So this is a monocarboxy peptidase. What's exciting about this enzyme is it converts a very pathogenic peptide into a peptide that's very protective. So it really is nature's ACE inhibitor. I mean, that's a pretty accurate way of looking at this. It converts angiotensin 2 into angiotensin 1 to 7. So naturally, if you enhance this side of the pathway, this will be protective. If you stimulate this side of the pathway, this is disease-provoking. So this is the concept how to use then ACE2 as a therapy in patients. So clearly when you have less ACE2, the renin-angiotensin system is out of control. This leads to cardiovascular and kidney disease. If you have high ACE2 level, for example, if you therapeutically manipulate this pathway, it leads to heart disease. So we're now moving into clinical trials, and this is getting very exciting, using human recombinant ACE2 as therapy for patients with cardiovascular disease. But I want to go back to showing some of the basic science data behind this. So the obvious question is, what happens to ACE2 levels in dilated cardiomyopathy? So sort of your run-of-the-mill type of heart failure phenotype. And this is the data we obtained from, I know here in Guelph, you're very good at collecting dilated cardiomyopathy hearts from animals that have been euthanized because of their advanced heart failure. In Edmonton, we're very good at collecting dilated cardiomyopathy from patients who go for heart transplant. And so this is dilated cardiomyopathy. This is ACE2 Western blot, and this is down by at least 60% reduction in dilated cardiomyopathy. And again, the ACE2 activity, the same thing. If you do the staining for ACE2, you see very similar changes. So at least in patients with dilated cardiomyopathy, this is very exciting. ACE2 is dramatically reduced, very similar to what you see in an animal model. So this sort of translational connection between what you see in animal models and humans is very exciting. And with pressure overload, which is one type of heart failure, you get a 75% loss of ACE2. So a very interesting molecule. So then to tease this out a bit further, we actually produced a few models, I think that Tommy and Glenn and others have been using for a fair bit now, looking at pathological hypertrophy, and that's basically the hypertension and the post-MI model. So pressure overload model and an infarction cell death model. And these are, in this part of the world, in westernized countries, myocardial infarction and hypertension are now the most common causes of heart failure. Okay, so these are now the dominant causes of heart failure. Okay, this is a wonderful statement from the AHA talking about animal models of heart failure. And so one of the model clearly is an LED ligation model that we have used, and Zam Kasiri is the one who started this up in Edmonton for us. And this is data from the ACE2 knockout mice. So these are gain loss of function experiments. So these animals do worse. They have bigger hearts, and histologically and with echo, very much like the echo that you do here in Guelph. These hearts are bigger, and they have reduced function based on echo, but also hemodynamics, so lower contractility. So maybe not so surprising that with post-infarction, these animals do worse. So we went on to look at a pressure overload model and showed that with aortic banding, these animals clearly, this is sort of the conventional transition from pressure overload to a dilated cardiomyopathy. And in the ACE2 knockout animals, they basically do not go through that compensatory phase. They go straight into a dilated cardiomyopathy with a very sick heart upregulation of many of the pathological markers. BNP here is dramatically increased in these hearts. So they lack of ACE2 basically prevent you from compensating to a pathological stressor. So simply exacerbating heart failure in mouse models. And finally, so what we did then was to make a recombinant protein. So human recombinant ACE2 was made, overexpressing it in CHO cells, and this was isolated. And this led to a startup company, Apiron Biologics, with Joseph Penninger, started in Vienna when he moved back to Austria. So they made human recombinant ACE2, and this has now been purchased by GSK for only $250 million. And it's now progressed into phase 2 trial. So naturally, we wanted to test the human recombinant ACE2, and this is an experiment looking at angiotensin 2-induced heart disease. These are fibrotic markers here in the heart. With recombinant human ACE2, we can completely prevent that pro-fibrotic phenotype from angiotensin 2. Very impressive data, and this is PSR staining, trichrome staining, both interstitial fibrosis, you can see these blue markings here, but also perivascular fibrosis. These are dramatically reduced in response to human recombinant ACE2, almost completely eliminated by recombinant ACE2. We have also done very nice experiments in in using the SHR rat models, and we've shown that you can nicely antagonize the pressor response here with angiotensin 2. This is with placebo in combination with recombinant ACE2. Note that the response here is rather transient, so the pressor response isn't long-lasting, but a clear dramatic difference. Most impressively, though, is the changes you see in your plasma peptide. So angiotensin 2 is the bad guy, angiotensin 1 to 7 is the good guy, and as you can see with the recombinant ACE2, that angiotensin 2 levels that are dramatically elevated in response to angiotensin infusion is markedly lower. So a very potent enzyme that can dramatically alter your plasma systemic Ang2 levels. And equally important is the fact that your angiotensin 1 to 7, so the product of recombinant human ACE2, is dramatically elevated in response to that therapy. So very exciting data, not only in mice, but also in rats. And this is the SHR data. So these are very hypertensive rats, and if you give them recombinant ACE2, you will lower their blood pressure and lower their Ang2 levels and increase the Ang1 to 7 levels. So no big surprises there. And more recently, we have shown that this angiotensin 1 to 7 peptide, so the focus predominantly has been on angiotensin 2. We now know that angiotensin 1 to 7 is also a very active peptide, which is what makes this a very exciting enzyme, because it not only breaks down Ang2, but it actually generates a peptide that's active. So a very important conservation of energy, if you will, generating a peptide that's very protective. And here we've shown in a diabetic model, you can completely prevent diastolic dysfunction, cardiomyopathy in an obese type 2 diabetes model. And there is now very interesting data that this pathway is very important in diabetes and obesity. And Ang1 to 7 mediates a whole range of, and we have had other studies looking at this, a whole range of anti-inflammatory effects, not only in the heart, but also in the adipose tissue. And so this has become a very exciting target to look at therapies potentially for obesity and diabetes. So I do have just 4 more slides before I finish. And so where am I going with all of this? Well, we have many drugs that already target the renin-angiotensin system and the neurohumoral pathways. So how can we tailor this therapy for patients with heart failure? Here is one example in which we can tailor this. So it turns out the major source of angiotensin 2 in the heart, at least, may not be the ACE system. It may be an enzyme called chymase. We now have data supporting this in patients with dilated cardiomyopathy, and others have, that the major production of Ang2 in the human tissue is actually chymase. So this is a source of angiotensin 2 that's not going to be targeted by ACE inhibition. So now to target that Ang2, this would be a perfect place for human recombinant ACE2, because you would break that Ang2 down into Ang1 to 7, irrespective of how that Ang2 is produced. Okay, so an ACE-independent method, a very important paper that was published in JCI, showing that chymase, which is very linked to inflammatory condition, can generate angiotensin 2. So this is one potential way in which we can apply human recombinant ACE2. So here is going back to the patients now. So this is an experiment we did, and there are a few questions coming up for the audience. So this is a mass spec system that took us a decade to set up, in which we can quickly measure peptide levels in patients' plasma. And we can do this at a very, very low level, down to picogram per ml levels in patients, and we can do the whole thing. We can do the profile, all of the peptides, and we can do this now for natriuretic peptides. We can do this for apelline peptides. This is angiotensin 2 peptides, by the way. So we did a control experiment. We spiked in angiotensin 1 to 10 into human blood, and then we measured the product. So this is when you spike the precursor peptide, what happens to that precursor peptide? You generate angiotensin 2, right? So this major bubble appears. It just shows how active that ACE system is. So most of your precursor peptide becomes angiotensin 2. Okay, so we did something to this experiment. What did we do here? What drug did we apply to the panel on the right? Rhetorical question. So we added an ACE inhibitor, right? So we just blocked all of that conversion, most of it, into angiotensin 2. Okay, so that's what an ACE inhibitor would do. And in fact, the signature, if you take a blood sample from someone, a patient who is taking an ACE inhibitor, actually this is one way to tell if your patient is taking their ACE inhibitor, they should have elevated Ang1 to 10, right? The biochemistry doesn't lie. Sometimes our patients do. So adherence is not 100%. So this is actually a very signature of fully activated ACE inhibition. Okay, so again, your control panel. So what drug did we apply to this panel? Any? No? Young folks here? No? All right, fine. Recombinant human ACE2, right? So now the angiotensin 1 to 10 remains low. Angiotensin 2 is lowered, but this angiotensin 1 to 7 bubble has now appeared, okay? So we have now shifted it downstream into angiotensin 1 to 7. Now what happens if you do, you apply recombinant ACE2 and an ACE inhibitor? This is completely, we have completely wiped out angiotensin 2 from a blood sample. Okay, so this is combination therapy. This is what we think we can use in patients that still have an activated RAS despite ACE inhibition. So for example, patients with active kinase and inflammation that are still generating angiotensin 2 despite ACE inhibition, we can now completely suppress that system by the use of human recombinant ACE2. One concern that you probably have in your minds is what happens to the blood pressure when you do this in a patient. Well, so as I said, this has made it into clinical trials. It has passed the phase 1 trial, and there's absolutely no hypotensive effects here of recombinant human ACE2. So patients do not, the blood pressure does not bottom out in patients with, okay, so this is this phase 1 safety trial. So very exciting that this is now, based on these results, this is now moved into phase 2 trial with GSK. And the lung injury trial has just been completed. The results are very positive. There's a marked suppression of Ang2, increased Ang1 to 7, and a very potent anti-inflammatory effect that they're seeing in that trials. Hopefully those results will get published very soon. So I want to finish up the last 2 slides with a message for translational medicine. So I think this is exactly what you guys are trying to build here. This is a very important article in Nature Medicine. So again, these slides are available for everybody. So they talked about how to create a translational. This is something Tammy has been obsessed with for the past while. How to build a translational interface incorporating all the major players. This is a great article to talk about how to do that. So one of the programs I've mentioned briefly about, and I think Glenn and Lynn is doing something very similar here, is we collect all our explanted hearts. So Edmonton has one of the largest transplant program. So we collect all of our hearts. It's often 2 or 3 o'clock in the morning. So there's a big demand here in personnel. And so not to be underappreciated, right? So you need motivated, hardworking people to pull this off. So we have now collected samples from 91 adult hearts, 26 pediatric hearts, and healthy donor hearts, well, non-failing control donor hearts, 22 of them. So we now able to isolate tissues from different chambers. We can isolate cells, cardiomyocyte, fibroblasts. We can now look at the coronary arteries, look at electrical activities in these hearts. So we're also now implanting a lot of left ventricular assist device, so we get apical samples from human hearts. So it's wonderful that Glenn and colleagues are able to do this with your dilated cardiomyopathy in some of the animal models. I think this is a great translational tool, and these samples are of course available for anyone who wants to use them. And then finally, none of this would be possible with hardworking people. Most of the ACE2 work has been led by Vaibhav Patel, a fellow who's now looking for a position, a PI position, and is applying across the country, and by Wang, a PhD student who is now will be graduating with his PhD in a month's time. And I would like to thank many of my mentors and collaborators, Peter Bax, of course, who I did my PhD with, and the iron overload story, Joseph Penninger, that of course we started the ACE2 connection, and Zam Kasiri, my favorite collaborator, and I will stop there. Thank you.
Thank you very much, Dr. Odi, for a fantastic seminar. I'm sure you're prepared to take some questions.
Yeah, sure.
We'll do just that for a couple of minutes. Who's going to start us off?
Oh, Lynn, yeah.
That was an amazing talk, thank you. I'm just wondering where, in the total scheme of things, that angiotensin receptor blockers currently fit, and
Right.
why haven't they kind of taken off as the
Yeah.
next greatest thing?
So they are they are important drugs in patients who can't tolerate ACE inhibitors. So they are second-line agent, and so you would use them for sure. But one of their problems is, and we now have the data. We have done a study now looking at heart failure patients on different types of therapies. Your plasma angiotensin levels are quite elevated in patients. When you block, it's a classic pharmacology. You block the receptor, the agonist will increase, right, as part of the negative feedback loop. So with that elevated angiotensin 2, whenever your receptor becomes unoccupied because of waning drug effects, that's a clear problem. So they are still important, that they are second-line agents, but they probably will remain as second-line agents. There are now other drugs that are coming on board, the angiotensin receptor with the nepresilin inhibition, the ARNI or Nesto just has been approved for human use, and I'm sure you'll be trying them out too in a veterinary clinic. So they do have a role, but I think their role will be continues to be limited, and probably will even be less of a role down the road as new therapies emerge. Yeah.
I was fascinated by the RAS pathway bubbles and
Right.
how you can kind of really show the effect
Yeah.
of things. And I just wanted to kind of clarify and see if I had sort of
Mhm.
an idea, which is that so you can take like a blood sample
Right,
and
right.
put it through like mass spec and
Yes.
get signatures, quantitative signature
Right.
markers
Right.
of all the different components of the
Yeah.
nervous system. Is that the
Yeah,
idea?
absolutely. And so the trick was, so it's not radioactive, right, which is a big plus. The trick is actually two things. One is you put a heavy label internal control. So you just replace your nitrogen or oxygen with a heavy label. So it moves slightly differently than the native peptide. And so you control for any degradation that you have in your sample. So it's an absolute control, non-radiolabeled. And the second major breakthrough was being able to isolate the peptides from the plasma matrix. So the plasma has lots of proteins, large proteins, albumin being the largest, immunoglobulin. So you do have to isolate that peptide cocktail from the plasma very effectively, and then using the heavy label, non-radioactive internal control, we have been able to go down to very low levels now. And so, this has been very helpful. And so we've now completed a heart failure study in heart failure patients with different types of therapies. And, it's very exciting. And recombinant human ACE2, at least looking at their blood, clearly produces the same effect we've seen here that I've shown you. So, yeah.
How are you getting the patients to test the recombinant human ACE2 on without having people that are already on ACE inhibitors?
Oh, yes, so they are on ACE inhibitors. Yeah, so these are patients are on ACE inhibitors or angiotensin receptor blockers, they're on beta blockers, they're on mineralocorticoid receptor blockers, namely spironolactone. So they're on optical medical therapy.
And there doesn't seem to be any detriment to almost completely abolishing the angiotensin II levels?
Right, so I mean, it's in phase 1 clinical trial went fine, no problems. Those were healthy volunteers, right? So there was no drop in blood pressure, which is surprising, and I'm glad you brought that up. So it turns out that ACE2 does modulate another peptide system, the apelline peptide system, and so that's why we think the blood pressure doesn't fall. So that might be good news, bad news, depending on which way you look at it, right? So one of the problems with ACE and ARB combination, so people have tried that combination, ACE and ARB combination in patients with heart failure, and the on-target trial, which was done here from Hamilton, they have adverse outcomes. So if you lower patients' blood pressure too much, you get into hyperkalemia, renal failure, and symptomatic hypotension. So it is a concern when you're trying to block the RAS excessively. Renin inhibition also is another potential target. Those will probably fail and probably will be taken off the market. So it is a great question, clearly a safety issue. In the human phase 1 trial, they did not see any side effects, but those are healthy volunteers, patients with intact cardiovascular system, not on any other medications. So the phase 2 trial was also positive, right? So at least one of the phase 2 trials. So it is something for us to think about as we apply it to patients with heart failure, but it goes back to the introductory slide. Why not use it in patients who are taking ACE inhibitors and the other drug, but have elevated plasma Ang2 levels? So that's the group we probably should target with the recombinant human ACE2.
Question about?
Yeah.
Is the mass spec, is that your discovery platform for the potential targets, or is that more your intervention?
Well, it was done with a group in Vienna, APRM Biologics, as part of their technology. So that's a group we've been collaborating with for the past decade. So that's the kind of fingerprinting of the renin-angiotensin system.
But do they use, is that what they use to identify potential targets, or is it more to monitor your intervention?
It's mainly for monitoring, but this technology now can be used for many different peptide systems. So natriuretic peptides, which are very exciting targets, the new class of heart failure medication, the RNA compound, is targeting natriuretic peptides. So it's to look at that. You can also look at apelline peptides, and I think many other peptide families. But you know, the concept is you have to be able to isolate your peptides very effectively from the plasma, and with the use of the mass spec liquid chromatography and the heavy labeling system, you can get down to very low levels. So it's a technology that can be easily be done here. Elsewhere. I mean, it's not, there's really no magic behind it, but you do need dedicated HPLC staff and a mass spec staff to really work with the technology and make it viable.
I'm going to take chair's prerogative here and say
Yeah.
I was struck by a curious observation in the first LCMS spectrum that you showed us, which was treatment with that was the ACE1 inhibitor. And what intrigued me about that finding was that you clearly you've messed up the conversion of angiotensin to angiotensin II. Yeah, it's this one right here. This one, yes.
Yeah.
So I was rather struck by, so you've spiked in having labeled angiotensin 1.
To set 1 to 10, yeah, the precursor peptide,
Exactly,
yeah.
and you've depleted, and obviously you've depleted then the pool of angiotensin 2
Two.
that you get. So the peptide that really struck me was the one on the left-hand side there.
Yeah.
What is that, and why does that appear?
That's a great question, and so that's our paper that we're submitting in 2 weeks.
Sorry, I had no idea, this is not planned.
So one of the new targets for ACE is actually Ang1 to 7. So Ang1 to 7 is cleaved by ACE to this peptide, angiotensin 1 to 5. So, and it's the end domain of ACE. ACE has 2 domains, ACE2 has 1 domain. So, and with the use of ACE inhibitor, Ang-1-7 levels go up. And we see this in our patients. So maybe one of the benefits of ACE inhibition is actually promoting Ang-1-7 levels, not by producing it, but by preventing its degradation. Yeah. So Ang-1-7 does go up with ACE inhibition. It's because ACE does degrade Ang-1-7. So ACE inhibition then increases Ang-1-7. Absolutely. There's no doubt about that connection.
And by the way, this is a beautiful way to display LCMS results. It really, it was very intuitive.
Okay, great.
Any other questions? Well, with that, I'd like to thank Dr. Obeek for an absolutely excellent presentation.